Yes, Doc.
Okay, so this is the course orientation for oral pathology 2. As you have noticed in the main lesson in activity 2, which is the content notes, you have there oral pathology and general 1 and general pathology as the prerequisites for the course. You have the objectives and you have the course content. In the course content, you might notice that oral pathology 2 is basically more concentrated on oncology, or this is in relation to neoplasia. Neoplasia being not only malignant, but also benign in entities in the oral cavity, found in the oral cavity. So you have there the content for P1 as well as for P2. If you noticed in the P2, I included their genetic basis of diseases. Then you have nutritional concerns for oral cancer patients and also current trends in oral cancer diagnosis and treatment, which are, I think, would be very important for you when you start your practice later on. We also have the house rules and the references used. Our textbook is uploaded into the materials and as well as supplement slides for you to review at a later time. So the same with oral pathology 1, you have what kind of a learner you are, and of course the Pomodoro technique that I always would emphasize to you as one because it's very effective for me, but I don't know if it would be very effective for you. But just try to use it. It might be very effective for you as well. So at this point in time, do you have any questions before we proceed to the next module, which is about neoplasia?
None so far, Doc.
Okay, thank you. So let's go to neoplasia. What is neoplasia? You might be looking at you might be looking at patients that would come into your clinic presenting something like this. Neoplasia is known as new growth. You can either use neoplasm as a term or tumor, and it refers to abnormal masses of tissue, so the growth of which would be separate or autonomous from the normal tissues, and as well as it exceeds the normal tissues in its growth patterns. The growth persists after cessation of the initiating stimulus, because in some forms of diseases that we have met in oral pathology 1, once the initiating factor is taken away from the site, the growth usually would stop. But in neoplasia, it's different. Even with the stimulating factor not present anymore or has been removed, the neoplasm will continue to grow. So according to clinical behavior, it can be benign and malignant. And benign can be characterized as having slow growth. It's mostly encapsulated, circumscribed, or encapsulated, meaning it is very distinct in its form, usually of good resemblance to tissue of origin, the cells of which would look similar to that of the tissue origin, low to normal appearances, generally normal nuclear features, usually no necrosis, no local invasion or distant metastasis or distal metastasis. For malignant, it's usually having rapid growth, irregular and poorly defined borders. It's not compared to um, the benign forms wherein the uh, benign forms are usually encapsulated or well circumscribed. You have a variable to often poor resemblance to tissue of origin, high, often abnormal mitotic activity, hyperchromatic pleomorphic nuclear features. So it means that the nucleus have different forms and it's highly staining. It's dark staining, so it would absorb more of the stain. And necrosis is always present with local or distant metastasis or distal metastasis. So when you say local invasion, uh, the nearest area would be invaded by the tissue or by the malignant cells. While if you have distant metastasis, it would mean that the group of malignant cells that have grown away from the anatomic site of the tissue. So, what are the components? Clonal expansion of neoplastic cells. So, there's a clone. They have the same genetic material and supporting stroma composed of non-neoplastic connective tissue and blood vessels, mostly because they would secrete angiogenic factors, which would tend to stimulate new formation of blood vessels. And then abundant collagenous stroma, or this is what you know as desmoplasia, and such tumors are rock hard, or this is serous. So it's very hard in consistency, like rubber-like consistency. For nomenclature, you have here, according to tissue of origin, for epithelial, it usually would end carcinoma in malignant forms, while in benign forms it would be oma. So for squamous cells, which would look the benign forms, which would look like finger-like projections, you have papilloma. Glandular, it's adenoma. Then transitional epithelium would still, and as well as basal cells, would look similar to that of the squamous cells in the form of a papilloma. Now, of course, for malignant counterparts, the name would be squamous cell carcinoma. Then you have glandular forms would be adenocarcinoma, transitional cell carcinoma, and basal cell carcinoma. Now, how about for mesenchymal tissues? So for mesenchymal tissues, the benign forms would be oma still for some, because there are exceptions to the rule. Then you have also here sarcoma as the family name for malignant counterparts. So if a smooth muscle, it's leiomyoma for benign and leiomyosarcoma for malignant. Then for striated muscle, it would be rhabdomyoma and rhabdomyosarcoma. For blood vessels, it's angioma and angiosarcoma. And for connective tissue, it would be fibroma or fibrosarcoma. So for nerves, neuro, then adipose tissue would be lipoma, and liposarcoma. Then cartilage, it's chondroma. Then you have bone osteoma and osteosarcoma. So you have here for the connective tissue neoplasms or for mesenchymal forms. Now, here is the exception to the rule. It does not follow whether it's benign or malignant. Now, for lymphoid cells, hemopoietic cells, melanocytes, and embryonic tissue, you would have the oma as its nomenclature, contrary to the rule that the benign forms would have the word oma and then would have either sarcoma or carcinoma. These are exceptions to the rule. Now, why is it that it's not changed into because it's highly accepted. And also, you do not have any classification because the tissue of origin would be blood cells. It's not a mesenchymal cell. It's not a connective tissue. So that is why they retained their previous names. They may mean, if you look at them, they may mean benign in form, but however, it's not a benign in form. It's going to be malignant. So for lymphoid cells, lymphoma. For hemopoietic cells, the RBCs, it would be for hemopoietic cells, it would be leukemia. Then for melanocytes, it would be melanoma. And for embryonic tissue, which has a benign counterpart, you attach the form either benign or malignant teratoma. I hope that would be very clear with you. So you have characteristics of differentiation. The differentiation here refers to how closely tumor cells would resemble the normal cell counterparts. You have anaplasia, lack of differentiation, benign and malignant characteristics. You have pleomorphism, variation in the shape and size of cells, and or of the nuclei. Then you have abnormal nuclei, you have hyperchromatism, or you have their increase in uptake of the stain. You have irregular clumping of chromatin and prominent nucleoli and increased nuclear to cytoplasmic ratios or abundant or atypical mitosis and loss of polarity. What does a loss of polarity would mean? If you notice, cells, healthy cells would have a characteristic placement of the nucleus inside the cell. It can be in the center of the cell or it can be in the periphery of the cell, depending on what type of cell you are looking at. With loss of polarity, the normal placement of the nuclei is not followed. So for example, you have a squamous cell. Most often, the squamous cell nuclei would be in the center of the nucleus or of the cell. But if it would have a loss of polarity in cancer, you have at times nuclei that is located on the periphery of the cell, which is uncommon for squamous cells. So that's loss of polarity. So you have tumor giant cells that can be present. You have ischemic necrosis because of the fast rate of mitosis and proliferation. So cell division is at a very fast rate. So at times there would be necrosis that you can find. And you have dysplasia. The rates of growth could be faster than the normal cells, and the portion of tumor cells that is actively proliferating is known as a growth fraction. So in general, but not always, the growth rate of tumors inversely correlates with the level of differentiation. So if there would be better differentiated or poorly differentiated forms, meaning the cells do not look similar to the cell of origin, it grows fast. There are also cancer stem cells and cancer cell lineages, and it's clinically detectable in a tumor wherein you have a heterogeneous population of cells originating from a single cell that is cloned. So this is where mutation comes in. The mutational ability of the cells in cancer cells are so diverse that you will see a lot of different cells, different forms of cells. You have local invasion. So why is it like that? Because they are not cohesive anymore. It means that there is no intercellular attachments anymore. And most often, malignant neoplasms would tend to invade the surrounding tissue by producing podocytes that you can see in the picture. That's why they can move around and invade. While metastasis is an invasion of the lymphatics, blood vessels, or body cavities, followed by transport and growth of smaller cancer in the breast. Cancer in the breast is the main or primary organ location, but it can metastasize first in the armpits, pwede, in the armpits, especially in the armpit, or it can even go to the bone or go to the lungs and go to the brain. So when you have classified already as that of stage 4 cancer, findings in the lung or the brain, it's already the terminal form of cancer. You will just have to wait until the person will die. So recognized metastatic routes, you have the lymph nodes, the blood route, transcelomic, and implantation. So if it undergoes metastasis to the lungs and the brain, these are already the last organs that are invaded and thus are already classified as stage 4 or terminal cancer. There can be seeding of body cavities, lymphatic, and as well as hematogenous spread. Okay. This is an old data from DOH. Malignant neoplasms ranks third as the 10 causes of death in the Philippines during that time. And it still is true until now. Recent findings or recent data from the DOH, although it's not yet published, still number 3. Philippines still is breast cancer for women and prostate cancer for men. Although there are times wherein colon cancer is already on the rise, and also as well as cervical cancer for the females are on the rise, and for men it's still there is still a significant number for lung cancer because of smoking, and liver cancer because of alcoholism. So there are genetic predisposition for cancer. It can be an inherited cancer syndrome. You can review this later. Inherited autosomal recessive syndrome of defective DNA repair, or you have familial cancers. It runs in the family. There are also non-hereditary predisposing conditions which could develop into cancer. Like there are areas of high proliferation rates, chronic inflammation, and conditions. Now, everything is going to be stepwise. It's not going to be like the patient sleeps at night and when he or she wakes up in the morning, she has cancer. He or she has cancer already. It's not that. It takes years to develop. And there are essential alterations of malignant transformation. So here is not develop overnight. because there would be mutations that would go on and on until it reaches this big. It's not going to be overnight. It takes years to develop. So I hope that is very clear with you. Here is another one that would tell you that it develops not overnight or over the weekend or over the week, over a month, but it takes years for it to develop. So this one is the normal mucosa. Then you have these plastic changes. It's a multi-step progression of oral squamous cell carcinoma until it would go into carcinoma in situ, or this is cancer within, before there would be invasion. So read this late at a later time. This is just information for you. So for your information purposes. There are carcinogenic agents. So you have chemicals, either radiation as well, UV and ionizing. Ionizing radiation, one cause of thyroid cancer for dentists is that when you use your x-rays without you being protected by the lead apron. So it's not going to be the patient who is going to undergo the x-ray that will wear the apron. You as the operator should also wear the lead apron. I hope that is very clear with everyone. Our new building is so big that I could not monitor already your usage of the lead apron because the x-ray rooms are on the ground floor. So I hope that when you use your in the area of the x-rays, you have there a lead apron, two lead aprons, one for the patient and one for the operator or for you. So you have oncogenic viruses and microbes. Microbes will be the Heliobacter pylori. This is implicated in duodenal and gastric ulcers. HPV, the human papillomavirus, Epstein-Barr virus, hepatitis B and C for the liver. There are host defenses against tumors, but most of them are overwhelmed. So they try at first to fight off cancer, but they are overwhelmed by the cancer. Okay. So these are the clinical aspects of neoplasia. You have bleeding and infection, functional activity, hormone production. You have location and impingement on adjacent structures. So that is why there are times if there would be pain that the patient can feel, and symptoms from tumor rupture or infarction and wasting. So you have skin and bones. So we will take upgrading and staging at a later time with your other modules. Are there any questions as of this moment?
None so far, Doc.
Okay. How about the others? Do you have any questions with regards to neoplasm?
None so far, Doc.
None, Doc.
Okay. Okay, thank you. So let us proceed to oral cancer screening. So for oral cancer screening, the main objective is to decrease oral cancer morbidity. That you might be, these are, you can read this at a later time. Now, what is the role of the healthcare provider as a future healthcare provider. So we are the best qualified personnel to examine the oral cavity. No doubt about that. Professional obligation to optimize our abilities to detect diseases, provide preventive counseling about risk factors and proper nutrition. Proper nutrition, dentists are not only to do diagnosis and treat oral diseases, but now we are mandated by the WHO to be a nutrition counselor. So you have to review back your nutrition subject. For whom is oral cancer screening? Every patient that comes into your clinic. Period. Why exemption? Pati bata? Yes. Why? There are oral disease, no, cancers, systemic cancer conditions that can manifest in the oral cavity, like leukemia. So we need to have them undergo oral cancer screening. So for the 90-second oral cancer examination, it is a comprehensive oral exam. Oral exam that you use every day, but it's more comprehensive. It would only take 90 seconds. Now, on your first try, it would take minutes. Some would even have 30 minutes. But as you go along practicing it, you would take note that it could only take 90 seconds, so more than a minute. So you have to preview the patient's medical and dental history. Then you have to do extraoral and intraoral inspection. So for um, extraoral inspections, as soon as the patient comes into your office, you have to take note of the patient. You have to take note how the patient walks, talks, or how is the movement of the arms, and as well as the head. You have to take note of that, and as well as the color of the hue of the color of the complexion. It's not being racist, but you take note of what is normal from that of the abnormal coloration of the skin. So it's not going to be a racist type of inspection. Then you do manual palpation of specific sites. Then you have early detection is critical and translate to improved survival rates, and this is recommended by the WHO. So if you look into the steps, the first one is extraoral examination. So you loosen the clothing around the patient's neck or ask the patient to loosen the neck area. Kaya at times, if you do it, you would be construed as something like, ala, gihubuan ako ni doctor. Remove the eyeglasses, remove dentures and other removable prosthetic appliances. Doc, naa siya braces. Suwayi og tang-tang daw. Hala, sige. It states here removable prosthesis. So that is not included. Document all findings, record suspicious lesions indicating location, color, size, shape, texture, and consistency, and ask for associated symptoms. So assess the general appearance. So skin coloring, gait, the way the person walks or sits or stands up, extremities, head and neck area, lips, you have muscles of the face, lymph nodes, and salivary glands. That is why if you're going to palpate the lymph nodes, it must be larger than 1 centimeter for you to be worried about it. Feels like peas or grapes under the skin, and it's hard and non-tender and fixed. So when you try to palpate it, it does not move. Have you noticed that the dentist does not palpate the extraoral site using the nails, but the pads of the fingers, kanang pads, because you can have gentle palpation for that. See? And as well as the lymph nodes in these areas. You have to take note that there are two groups that you are going to palpate. So your palpation would start at the back of the ear, going down a bit, and then to the face, going down to this area here, and under the chin area or under the mandible. These are your collar nodes. And you also have the descending chains that you are going to palpate. So with the same area, with the same palpation technique, it's both bilateral because on both sides of the neck, you're going to palpate these lymph nodes. So intraoral examination, you know the lips, the labial mucosa, this one here, the buccal mucosa, the cheek, this one here. I would like to ask you, what is this white line called? Can anyone answer that? The white line, this one here. Can anyone answer that? What is that white line called that you can see from here going there? This is a white line. Any? Yes, Perseus.
Focal hyperkeratosis, Doc.
It's a type of hyperkeratosis, yes, but there is a specific name for that. It's a Latin name. Yes, Miss Hainar, Chantal, it's Linea alba. Linea means line, alba means white. So that is the name of that line here, which corresponds to the meeting of the maxillary and mandibular teeth. It's hyperkeratotic, it is physiologic, it does not pose any, you do not have to treat it. This is more like it, this light white line here, that's the linea alba. So you look into the gingiva, you look into the dorsum of the tongue, here, specifically the lateral borders of the tongue, because this is where most of cancers would appear. Then the ventral surface of the tongue, the floor of the mouth. Anyone can identify these areas here, this growth-like structures here. Can anyone identify that? It's a form of bony exostosis, but it has a specific name. It is
Mandibulatory, Doc.
incomplete ka, Joshua. Before that, there's a word that starts with letter T. T
Taurus
for tango.
mandibularis.
Taurus mandibularis. You are correct. No, you're very much ready now for your um, clinics. How about for this one here on the palate? It's a bony exostosis as well. Anyone? On the palate. Yes, Perseus, you're correct. Taurus palatinus. In the clinics, I will be if there are clinical setting, so wait first. So in the clinics, I will be asking you again if by chance we see some of these structures, I'll be quizzing you. Okay. And points to remember, most oral cancers are located on the lateral borders of the tongue, the floor of the mouth, the lips, and the retromolar pads or the retromolar trigone. And you have to tell the patient what you are going to do with each procedure. You do not just barge in and let the patient open his or her mouth and then start poking around. No, you're going to tell the patient what you are going to do. So we will now proceed in checking your tongue. I will try to retract your tongue for a bit, like something like that. You have to tell the patient each step you're going to do. Now, what do you want to see for cases? You want to see leukoplakia or white patches. So here, or this one is already so big, this is already squamous cell carcinoma in a 45-year-old male heavy smoker and drinker. So this one is a carcinoma of the caruncle of the lingual frenum. You see that the patient is a chronic smoker and with poor oral hygiene. This one is an advanced form of oral squamous cell carcinoma. As well as this, it has eaten up the palate. So there's already palate perforation. And you have leukoplakia or white patch here. This patient is a smoker. This one is lip cancer. It's a sore that has not healed for 2 weeks upon examination. So biopsy was done and it was diagnosed as lip cancer or oral squamous cell carcinoma of the lip. This is a variant form of oral cancer or squamous cell carcinoma known as a verrucous carcinoma. So it has already invaded the whole of the tongue. The tongue has to be removed. You have squamous cell carcinoma near areas of jacket grounds and also here in this area of the palate. This is squamous cell carcinoma of the tongue. So the whole of the tongue has to be removed. This one is a 70-year-old patient. This is the verrucous type of carcinoma. This is the carcinoma of the maxillary sinus that has invaded the oral cavity. Actually, this case is a case in school of a tricycle driver who went there for tooth extraction of a very mobile, this is pre-pandemic, of a very mobile maxillary molar. But when I looked at the face, the right area was sunken. So I was really like, it's not a good sign. When we took a look at the oral cavity, this is what we saw. This is from the maxillary sinus. We referred the patient to Vicente Soto Memorial Medical Center, and we followed it up, but sad to say, the patient died of the cancer because it was already a terminal form. We did not just know it was a terminal form already. Had we done tooth extraction of the case because it was so easy to extract because it was highly mobile, sus kami unta, ang intern unta, ang mapasanginlan and the CI. Mapasanginlan unta to nga pwede tong makiha. But gladly the intern was like, "Doc, can you see this? There has a growth inside." So when I took a look at it, it was like, it's not a good one. But when I looked at extraorally, oh no, this is a cancer. So we referred. I suspected that it was a cancer. So we referred that the patient to Vicente Soto Memorial Medical Center, and he was diagnosed as having carcinoma of the maxillary sinus. But the patient the patient did not live long. The patient died of it. So basal cell carcinoma of the skin. This carcinoma has one of the most very good prognosis ever for the cancer, because once you remove this, excise this, the cancer will not grow back. This is melanoma. The melanocytes undergoing cancerous change. This is a pigmented form because you can see a melanin pigmentation. The most common form of which is the pigmented form. You have metastatic carcinoma. This one comes from the kidneys. So the primary site of the cancer was kidney, and then it metastasized to the oral cavity at the retromolar pad area. So adjuncts in oral cancer screening are available now in the market. You can use this. You have acetic acid plus swabs plus blue light. You can see the extent of it. Or you can have toluidine blue, which you can, it's a vital stain. You can see more of it clearly. So here, you do not know the extent, but with toluidine blue, you can see the final extent of the cancer. So here, you don't even know it's this is blue light and as well as acetic acid swab. But with toluidine blue, you can see the extent of it. It's really very big already. And you can have oral advanced kits, which is cytology testing. You can even have, this is like a swab. So delays in detection, according to a model by Dr. Anderson, you have appraisal, self-appraisal, self-diagnosis, help seeking, not from the doctor, but from the neighbor, from the friend. Call a friend. Diagnostics, self-diagnosis, and pre-treatment that could cause the delay of the diagnosis. So strategies would include patient awareness, practitioner training, health system and policies, and research. Practitioner training, it means that when we graduate from dentistry, it does not end there. We still have to study. That is why I would really advise you to take your postgraduate courses. Now, you might be asking, Doc, what will I do with biopsies? Is there a need for a biopsy? Well, this is a guide that I made for you. This is actually taken from two references published in 2002 and 2004. I made a summary of it, and this would tell you points to consider prior to biopsy and guidelines for appropriate biopsy for general dental practitioners. So if you notice that if you have cancers, white patches, or any other forms of granulomatous diseases, if there is a need for biopsy, biopsy is not for general dental practitioners. You can see no, referral to the hospital, no, urgent referral to hospital, no, referral to hospital, no, referral to hospital. Mucocele, yes, but with care. Fibroepithelial polyps, yes, but minor salivary gland and major salivary gland tumors, no, you have to refer to the hospital. So you might be asking me, why, Doc, what is the most appropriate biopsy procedures we can do in general practice? So you have here either oral cytology, aspiration, fine needle aspiration, incisional and excisional biopsies. So for the fibroepithelial polyps and as well as that of the mucocele, we can do that. So for aspiration biopsy procedures, you make use of the needle set. You have the syringe and the needle. You poke it into this area here that you want to aspirate, and then you aspirate. So if the aspirate would be straw-colored fluid, it's cystic. If you have blood, it's a vascular lesion. And it's negative aspirate, it can be a solid tumor of cells that would need not the aspiration technique, but you need either an incisional biopsy. If, for example, the growth is larger than 1 centimeter and it is located on a hazardous location, meaning the anatomical area would present very sensitive structures in there and there is a great suspicion of malignancy, incision biopsies would be best. So how do you do incision biopsies? You take a desirable narrow biopsy, including that of normal tissue. Why? You need to have margin studies and you need to have a comparison of normal tissue. And since incision biopsies are very small, you need to have them sutured. So there's a suture thread because in times of accidents, ma-accidentally swallowed, you can still pull out back the tissue with the use of the suture thread in it. And also, if the lesion or the growth is like this big, there is no point of doing excisional or removal of the whole tumor in there because this would cause fracture in this area here, but incisional biopsy is good for it. And for excisional biopsies, removal of the entire lesion. So if the size is small, but you need to also include normal tissue around it. So let us look at a sample here. So this one is a growth on the lip. With anesthesia, you anesthetize it and you do an elliptical cut. You take that out. You have a wound here. And then you do releasing incisions on the sides I-release nimo ang tension on the side. So cut on the side so that it will co-update when you do your sutures. And this could be done by general practitioners. Then after that, you're going to submerge your, well, this is not the small one, but this is a sample of fixation in 10% formalin. I do not suggest 95% alcohol. Label and immediately submit to the pathologist, the form of which would contain the biographic data, name, age, sex, etc., brief history of the lesion, clinical appearance and surgical findings. If you can draw it, the better. And tentative diagnosis together with the specimen. Because early detection is good for the patient. Do you have any questions? Naaba mo'y mga pangutana. Was everything clear? None. Okay, thank you. So if there are no questions, the link for your quiz is already open, but I have an announcement. Our next RAD learning session falls on Wednesday, June 28th, which is a holiday. It's the Eid al-Adha, or the Day of Deliverance. And you will do your RAD learning session on your own. I will post the slides. You can do it whole day. I will open the RAD learning session or the links. I will open it at 8 in the morning and it will close at 5 in the afternoon. So you have to still do your RAD learning remotely on your own. If there would be questions about what you have done in the RAD learning session, you can ask it the following meeting. That would be on July 3. So is it clear? So you still have to do the RAD learning session on your own for modules number 4 and 5. I will open it at 8 in the morning and I will close it at 5 in the afternoon. So I hope the announcement is clear. So should you not have any more questions, the link of your quiz is now open and will close at around 7 in the evening. So see you on July 3. Keep safe, everyone. Enjoy your Maroon Jam tonight if you are here in Cebu. Take care, everyone.
Thank you, Doc.
Welcome.
Thank
Welcome.
you,
Thank you,
Doc.
Doc.
Thank you, Doc.
Thank you, Doc.
Thank you, Doc.
Welcome.
Thank you,
Welcome.
Doc.
Nag-echo.
Welcome.
Thank you, Doc.
Thank you, Doc.
Welcome.